We're ready to start the last portion of our evening now. I just wanted to give you some information. So we'd like to introduce the Canadian Gastric Cancer Association. So Sunnybrook's been working on this amazing website, and we at My Gut Feeling, we get a lot of questions asking, what are the available treatment options for patients? What are the available clinical trials? And Teresa and I, we just look at each other and we're like, we don't know, go speak to your doctor. So Sunnybrook's been working on this amazing website for patients and providers, and it's all about treatment options and clinical trials and information about gastric cancer that's better research than something that I could do. So thank you so much, Dr. Coburn, for bringing this to our attention.
So our next speaker is one of my heroes. She was my radiation oncologist, and she was absolutely amazing through my entire treatment. Dr. Jolie Ringash is a radiation oncologist and site leader for the GI Radiation Oncology Group at Princess Margaret Hospital. She is a co-chair of the Quality of Life Committee at the Canadian Clinical Trials Group and a professor at the University of Toronto. Her research interests include quality of life, cancer survivorship, and high-precision radiotherapy. Dr. Jolie Ringash. You have her? Just go.
Thanks very much. I'm so delighted to be here today, and I wanted to especially thank Katie and Teresa for inviting me. This isn't the kind of talk that I give very often, so I was just chatting with Dr. Swallow at the break that you may think that we're really used to this, but it can be a little intimidating when we're talking to an audience we're not used to addressing in a group like this. I have lots of conversations with patients. It's usually more one-on-one. So hopefully it will be gauged at a level that's helpful for you. So as you heard, I am a radiation oncologist. I see patients every week. I have several clinics a week. And I have no financial conflicts of interest, so I'm not going to try to sell you anything. But my interest in stomach cancer came about pretty naturally because I was interested in gastrointestinal cancers, and I happened to come along just at the right time. Up until about the year 2000, the main treatment for stomach cancer in terms of curative treatment was surgery. It's still surgery today. But up until that time, we didn't really think there was much else we could do. If the operation didn't work, then we were talking about chemotherapy, but there wasn't really a way to stop the cancer or prevent the cancer from coming back. And then at the American Society of Clinical Oncology, which is the big international meeting for cancer that happens every year, it's always in Chicago now, in the year 2000, for the first time, there was a big study presented that showed there was another way to add on to the effect of the surgery and to cure more patients, and that included radiation. So for me, at the beginning of my career, it was a great opportunity to sort of dive into something that was new and exciting and provided new opportunities for patients. So what I'm going to talk about today, I'm kind of going to go back to basics. I'm going to talk about what is radiation, how it works, some of the toxicities and the indications, and also apply that back to stomach cancer. Now, a few of my first slides may take you back to your high school physics class. So if that's a bad memory for you, please feel free to close your eyes. I promise I will explain it if the pictures look too yucky or scary. So we're going to talk first about what is radiotherapy. So this is what we call an electromagnetic spectrum, high school physics, right? So radiation is here, this is X-rays, but I just want to point out that this isn't all so unfamiliar. This is the visible light that's surrounding us all the time. Infrared, which is heat, that's how we cook our food. Microwaves, we also use to cook our food. Radio waves. So really all that radiation is a type of electromagnetic wave that's around us all the time that just happens to have more energy and a shorter wavelength than the sunshine that we absorb every day. So it's nothing super magical. It's just something that shines on you. It just happens to have slightly different effects. How does it work in the body? How does it kill cancer? Well, probably many of you have seen this very pretty picture. That's the DNA double helix discovered by Watson and Crick. So this gets sort of thrown about. It's all over the place on websites now, but that's basically the template. You can think of it as being kind of a map for the genetics of the body. So when we were talking earlier about hereditary cancer and genes and genetics, this DNA is the way that that gene information is encoded in our bodies. And it's the main target for radiation. So if you were to take this fancy twisty thing, if you imagine it like a curl ribbon, and you were to twist it, untwist it, and flatten it out, then what you'd get is this thing that looks a bit like a train track. And you have 2 rows of proteins that are in the body, and they're connected together by bonds. And then that curls up and creates this DNA. So there are a lot of things that happen, just little insults and damage that happen to us every day that can damage this DNA, and it can cause breaks. And if it only breaks one side of the train tracks, well, that's not a problem, because the other side is there. It almost works like a magnet. It attracts back whatever protein it makes, and it fixes things, and it usually fixes them right. But when you come along and you blast right through both sides of the train track and you've got a big gap like this, it's a lot harder for the body to repair that damage. And sometimes it's not repaired properly. And then when the cell tries to reproduce, it can die because it's had too much damage to its basic map, which is the DNA. So that's how radiation works. Now, this looks scary. I'm going to talk you through it. This is what we call a cell survival curve. So what we have on the x-axis here of this graph is the dose of radiation going from 0, so no radiation at all the way up to a very high dose. And then on the other side, this, don't worry about the numbers, but basically what we're saying is 100% and 0. So this is how many of the cells that were there to begin with are still alive after we hit them with a dose of radiation. So if we hit them with a very high dose, we get into the realm of what we call stereotactic radiation, where the radiation is basically just acting like a laser. It's blasting straight through everything in its path. It's killing good cells. It's killing bad cells. And we do use this therapeutically in situations where we have very tiny deposits of cancer, small parts of the body where we can afford to damage the good cells as well as the bad cells and still have the patient survive. I'm not going to talk about that anymore today. If people have questions about it, I'm happy to answer them. But the rest of the time today, I'm going to be talking about what we call standard fractionation. So this is where we give little doses of radiation, low doses, but we give them oftentimes over a long period of time. So we're in this low dose area where we give a dose of radiation and we actually only kill a very small percentage of the cells. And then what happens is we do that day after day after day after day. So what you're seeing, this black line here, that's the same curve that I just showed you, that we just talked about, but we're repeating it day after day. So Monday, Tuesday, Wednesday, Thursday. And when we do this in gastric cancer, we're often doing this for maybe 5 weeks. So we do that, say, 25 times. So what happens, what this translates into, is the effect is as if we had a low, low dose of radiation that's in your body constantly. It's not in your body constantly. If you're getting radiation therapy, you don't have to worry. You're not radioactive. You're not going to make your children sick. But it acts that way in the body because we're giving repeated tiny doses. And what happens with that is that we take advantage of the fact that cancers are usually not able to repair damage as well as healthy cells. So what happens to the tumor is every time we hit it, it drops down, there's fewer cells, there's fewer cells, there's fewer cells. With the healthy cells that are surrounding it, well, they drop down too. That's why you get side effects. But there's more repair, so that doesn't drop down as much as the tumor. And over more and more time, if this is, say, 5 weeks or 7 weeks, what happens is you have a big difference between the amount of the cancer cells that are killed and the amount of the healthy cells. And so what we hope is that we can actually get to the point that we've killed all of the cancer cells, but there's still enough of the healthy cells that they're able to repair the damage, and the side effects will be temporary, but get better and heal. And this is another graph that's basically showing the same thing. It's just showing you once again, as the radiation dose increases from 0 to a high dose, this is the local control of the cancer in a patient now. So this isn't just a cell or a group of cells. This is in the patient altogether. That there'll be a certain curve showing that as we increase the radiation dose, we have a better chance of controlling all the cancer cells. Great, but as we increase the radiation dose, we also have an increased risk of serious side effects, some of which could be permanent and some of which could be fatal. So what we're looking for is this magical space in the middle, where the dose of the radiation is high enough to control cancer in the majority of people, but it's not going to cause severe side effects that can't heal in the majority of people. So we call that a complication-free control rate. And that's really what we're aiming for. And that's why when you talk to radiation doctors, they'll talk to you about a lot of different schedules, and it'll sound very confusing. And often patients say to me, well, how did you decide that I need exactly that number of treatments? And it's all related to this kind of research. So in addition to manipulating the biology of how the radiation works in our cells, we can also manipulate its physical properties. So what do I mean by that? Well, when I started training, back when I was a resident, as we all keep saying, if we shone a beam of radiation on somebody, it looked like this. So it was the same dose of radiation everywhere within that beam. So you might imagine maybe the area where the stomach cancer was removed is here in the middle. Up here might be your liver. Down here might be your kidney. We don't really want all those areas to get the same dose of radiation, but that's just the way it was because that was the state of the technology that we had at that time. Today, we can do something much fancier. This is what we call intensity modulated radiation. You might hear the term IMRT thrown around. And what that means is that we break that big beam of radiation down into many, many tiny, tiny beamlets, and they can each have a different dose. So if you want to give lots of radiation where the cancer's been removed, maybe it's right there, you can give less to the liver, you can give less to the kidney. And that allows us to create these very pretty pictures. So this is a cross-sectional CAT scan. This is as if we were, slicing somebody in the middle right through their midsection where their stomach is. And what you can see is this sort of brownish color is what I've indicated is where I want the radiation to go. And then you can see this blue line, which is indicating where the radiation actually went. And it's not perfect, but it's pretty close. It's pretty close to going where we want it to be, but sparing other organs. This is the liver, for example. These are the kidneys. So that's what we can do today. In spite of all these fancy bits of technology, however, there are side effects because you remember I showed you that while we're wiping out all those cancer cells, we're still damaging some of the healthy ones that are surrounding it. In the short term, a lot of these are stomach kind of symptoms. So feeling nauseated, perhaps throwing up, having a heartburn feeling, your appetite not being good, which is the last thing you need when you've already had part of your stomach removed, and tiredness. Tiredness can be a really persistent effect of any kind of cancer therapy, but definitely radiation. That's in the short term, and those things by and large heal and get better. But there are also what we call late effects from radiation. Unfortunately, it causes damage in the body that maybe doesn't completely heal, and that can either be related to what we call sort of subclinical damage to organs that then sort of begin to fail over the years, or what we call a consequential injury, which is basically scarring. So if the acute side effects are bad enough, if there's enough damage to those organs, then they can scar, and that could cause something to, say, block or stick together or to chronically bleed and be painful. Why and when do we use radiation? These are just very general. So for all kinds of cancer, we can use radiation to cure cancer. We can use it for palliative purposes. We've been talking a lot about palliation today, relieving symptoms. Or we can use it as an adjunct to surgery. So this can be before surgery, we call that neo-adjuvant, or it can be after surgery, and we call that adjuvant, so before or after. But the theory here is that the surgery is the most important treatment and the radiation is helping it or assisting it. Often that's done with chemo as well. Now, the not so wonderful news for stomach cancer is that we don't really have a curative option with radiation. And the reason for that is that adenocarcinoma, which is the type of cancer that we see most often in the stomach, requires a pretty high dose of radiation to be completely killed. And unfortunately, the stomach is located very close to a lot of other organs in the body that don't like radiation very much. The liver, the small bowel, even the healthy part of the stomach, and what we call anastomoses, that's where the surgeon has sewn things together. So if Dr. Coburn or Dr. Swallow have taken your stomach out, they have to link everything back up inside so that food can pass through you. And those areas where they've sewn things together are somewhat weaker, they're somewhat more vulnerable, and the radiation can damage them. So because of these things, then radiation is not generally an option for curing stomach cancer. For palliation, it works very well. So once again, this is controlling symptoms, and the theory here is that we would want to choose a schedule of treatment that's relatively short, so it's convenient for the patient, that would provide symptom relief with acceptable short-term toxicity. So we don't want to make people sicker than they already are. If we're not going to be able to completely cure the cancer, we want something that's going to be relatively gentle for them to go through, but that could help with their symptoms. And some of the common indications where we might use palliative radiation, bleeding is one of probably the number one indications for radiation, because radiation works very, very well to stop bleeding. And sometimes all you need is a single treatment at a relatively low dose to stop a tumor from bleeding. When cancer spreads elsewhere in the body, so if there's cancer that has spread from the stomach into the bone and it's causing pain, radiation can be helpful. Sometimes cancer spreads from the stomach into the brain, and that can cause confusion or problems with moving the arms and legs, numbness, stroke-like symptoms, so radiation can be helpful there. And occasionally this type of cancer can spread into the lung, either the lymph nodes in the center of the chest or the lung itself, and cause breathing difficulties. So radiation can work for all of those things. There's a very serious occasional complication called a spinal cord compression, which is where a deposit of cancer, usually in the bone of the back, will push on the nerves that control the legs and that also control the bowel and bladder. And this is really serious because it can fairly rapidly evolve into somebody being paraplegic, not being able to use their legs, and that can be a permanent effect. So this is usually in a situation where a person is not going to be cured of their cancer, but they might otherwise have many months of good quality of life. But if this particular complication happens, then all of a sudden they can't move around, and it's much more difficult for them to enjoy the last months that they have in their life. So this is one of the things that I always try to inform colleagues who are not radiation doctors about, especially family doctors. If you know a patient has a history of cancer and they come to you telling you that their legs are numb or tingling or their legs are becoming weak or they're having sudden problems with their bowel and the bladder, that's an emergency. That's a call the ambulance and get the radiation oncologist to see them that night, because if we can intervene quickly, we can stop that process from paralyzing a person. So that's not common. I don't want to terrify you, but if you or someone you love ever has those kind of symptoms, get yourself straight to the emergency room and tell them to call a radiation doctor. Okay. Now, one of the other problems that can happen to people if they're not able to have surgery to remove their cancer is it can start to block off the stomach. Unfortunately, radiation doesn't work very well for that, because one of the first things that happens with radiation is that the tumor starts to get a bit swollen. So before it shrinks, it swells. And what could happen is that an almost blocked stomach could become a completely blocked stomach, and then that could require emergency surgery. So we don't often use it in this situation, but occasionally. It just depends on the scenario and what else is happening with the patient. Now, the most controversial area of radiation for stomach cancer is this adjuvant thing, so using it as an addition to surgery in patients that we hope are going to be cured of their cancer. And that can be before or after, as we mentioned. It has a role to play in both. But there's been a lot of research done since that meeting I told you about in 2000, and at the moment there's some question about whether the radiation is really needed or not, or in which patients it's needed. So I'm taking you back to 2000. This was the ASCO meeting. I was in a room that is more or less the size of the Air Canada Centre, if you can imagine that, full of cancer doctors from around the world, and way, way far away on a tiny little stage, there was a man standing up and talking about this landmark clinical trial. And everybody was very excited because this is the first time that we saw any evidence of something that could work beyond surgery alone. And this was a 10% survival benefit at 3 years. They later showed at 5 years as well, for patients who all had surgery for their stomach cancer, and then half of them also went on and had some radiation and chemotherapy afterwards. Now, a 10% improvement in survival might not seem like a lot to you, but what that means is that for every 10 patients we treat, one person who otherwise would have died will be cured of their cancer and go on and live a normal lifespan. So that's actually, to us as oncologists, pretty important. So we went along for about 5 years happily giving this treatment to appropriate patients. We still do give it today. But then all of a sudden things got a little more complicated, because in 2005 we had another option on the table. This British trial, which was called MAGIC, I mean, what a great title for a study, right? I wish I'd come up with that. The MAGIC trial showed a similar 10% benefit, but in this case, what they were comparing was surgery alone versus surgery with chemotherapy alone, before and after the surgery, no radiation. Now, this was more intensive chemotherapy, so then that kind of left us with the question, is it better to give radiation and chemotherapy after surgery, or is it better to give more intensive chemotherapy and give it before and after the surgery? We still don't totally have that sorted out, I'll tell you right now. So there's 2 trials that have tried to answer this question. The first one was in Korea. They called it ARTIST. And this is, again, comparing patients with surgery alone versus surgery followed by some chemotherapy and radiation. And they did not find a significant difference. So even though this suggests that maybe the patients who got the radiation did a little bit better, this wasn't a very big difference, and it wasn't big enough that we're sure it's real. It might have just been, by chance. But what they did is they looked at what we call a subgroup. They looked at the patients who had lymph nodes involved with their cancer. So for this separate analysis, they took out all the patients who only had cancer confined to their stomach. And in the patients who had the more advanced cancer that was involving the lymph nodes, they did see a benefit that was big enough that it looked like it could be real. But this wasn't the first intention of the study. This is what we call an unplanned analysis. And those can sometimes be misleading, so we're still not really sure on the basis of that study. The second study that tried to answer this question about chemotherapy or chemotherapy plus radiation is a Dutch trial called Critics. And they basically gave the chemotherapy before surgery and after surgery, and then half of the patients, they added in the radiation afterwards. This showed no difference at all. But the reason it's hard to interpret this one is that less than half of the patients actually got the treatment after the surgery. So everybody got the chemotherapy, they went on to the surgery, and then the majority of them actually weren't well enough afterwards to get any treatment, whether it was chemotherapy or chemotherapy and radiation. So it's kind of hard to answer the radiation question because they ended up having a lot fewer patients who received the radiation than what they initially expected. So because of that, we have a couple of trials going on right now. The one that's available here across Canada is called Top Gear, and this is being run by the Canadian Cancer Trials Group in Canada, but it's centrally run by the Australians. And what happens with this is people who have a stomach cancer that looks like it's curable will be randomized, like a flip of a coin, if they agree, and half of them will get chemotherapy before the surgery, and chemotherapy afterwards. That's like the MAGIC, sort of. The other half, they actually get chemotherapy and radiation before. So that's what's a little different. They give the radiation before when people are still well enough to receive it. Then they have the surgery, and then they get the chemotherapy afterwards. And this started out using a certain group of drugs called ECF, and now it's using a group of drugs called FLOT, because in the meantime, another study showed that FLOT might be better for some patients. So the plan for this study is that 620 patients are going to go into it. That's a lot. That's why it's happening around the world. So far, there's 448. They have already looked at the first 120 patients because one of the fears that the surgeons had was if we give this radiation and chemotherapy before the surgery, maybe we'll make the patients too sick and they won't be able to have their surgery, or they'll have too many side effects after surgery. But they didn't find that at all, so most of the people were able to receive all of the treatment that was prescribed, and most of them were able to have surgery. And the risk of side effects, although 22% sounds not very nice when you're a patient, this is very much consistent with what we would expect based on the other research that's been done. So right now, we are in the situation we're still not really sure about the radiation. We have these 2 ongoing trials, so Top Gear that I've just spoken about, and the ARTIST-2 trial. That's the Korean trial where they selected out just the patients who had lymph nodes involved, and they're looking to see whether those patients will benefit from radiation. So what do we do right now? Well, right now in my clinic, when I see a patient who has a surgically resectable gastric cancer, we have a conversation. We talk about these 2 options. We talk about the pros and cons. What are the side effects? People often have many thoughts that are important to them about what they want to do, and that's how we make the decision. But I think that the most key thing is really for people to get to a cancer center and see a chemo doctor, see a radiation doctor, so that they can make this decision, because we still have scenarios where a patient maybe had surgery in a smaller community, they didn't get a chance to see the chemo doctor or the radiation doctor, they just went for the surgery, so they've had surgery, and now we don't have as many choices. We can do the radiation and chemo and the radiation and chemotherapy that comes after the study from 2000, we can do that because that's all afterwards. But we no longer have the choice of saying to do the chemo before and after, and of course they can't participate in these studies because they've already had their stomach removed. So I think that the key thing right now for anybody with stomach cancer, if people are asking you for advice, is try to get to a hospital where people have experience, where they know about this, and where we do these multidisciplinary discussions where we involve the surgeon, the radiation, and the chemo doctor, as well as many others, right from the beginning, so that we make sure you're given all the options and you can make your own choice. And that's it. I just want to say thank you to my colleagues in the GI site group, as well as our foundation and Elixir, which is our survivorship center, just to give that a little plug. Thank you very much.